Good evening. I'd like to introduce Konrad, who's a consultant neurologist at Southmead Hospital in Bristol. He's going to talk to us this evening about advanced therapies that are available there. I apologise that the first minute of his talk has not been recorded correctly. So he's going into his introduction where he's talking about what he's going to discuss this evening.
I will briefly talk about generally advanced therapies and what about indications and contraindications to them, and then I will talk individually about the three main ones, which are apomorphine, Duodopa, and deep brain stimulation, and also a little bit about MRI guided focused ultrasound ablation for tremor, even though it's not really approved yet for Parkinson's, for use in Parkinson's. And then we should hopefully have enough time for questions. And you can, as Jane said, you can submit your questions for the Q&A session. So you can see here the stages of Parkinson's, and there are many different classifications of progression of Parkinson's. I use this one because it focuses on treatment, and you can see that initially when patients are diagnosed with Parkinson's, they can be diagnosed very early when the condition is mild, and people may not even need treatment initially. At some point, however, the treatment will be necessary, and they may be started on one medication. And at the beginning, even for a couple of years, this may be enough. Their symptoms may be well controlled. At some point, as Parkinson's progresses, most people would require more than one medication, and the treatment of the symptoms may be suboptimal. So even in their best on state, when the medication is working well, they may still have some mild symptoms of Parkinson's. This may then develop to, sorry, I'm just trying to get my pointer here, to response fluctuations where patients are quite well when they have taken the medication, but then the tablets wear off, and 15, 20 minutes, half an hour before the next tablet is due, patients may experience more stiffness, slowness, or tremor. And at this stage, it may be helpful to add another medication, third one or fourth one, to their regimen. But at some point, those fluctuations are very difficult to treat with regular oral medication. And I should have mentioned that all of those treatments are oral treatments, so these are tablets or capsules. At some point, however, the fluctuations, meaning off periods, and dyskinesia, meaning excessive movements, may be unresponsive to treatment, at least to the tablet-based treatment. And at that point, we should seriously think about starting advanced treatments. We can already start looking for advanced treatments here at this stage, and people may start reading about them, but really the treatments can only be started according to the current criteria at this stage. Now, what is advanced PD then? Well, it's not, there is no simple definition. You can say that, or one can say that advanced PD is the stage when oral therapies are insufficient, and we may need to think about non-oral ones. But you can also think about it as a constellation of symptoms. and those green ones here, like motor fluctuations and dyskinesia, may coincide with other motor symptoms in red here, like rigidity, stiffness, axial, meaning that it's the center of the body, so neck, legs, instability, dysarthria, meaning slurred speech, and dysphagia, meaning problems with swallowing. These motor symptoms may become prominent in advanced Parkinson's, or in complex Parkinson's, as it is otherwise called. There are also some non-motor symptoms that may become prominent, like cognitive impairment or dementia, or psychiatric or autonomic symptoms. The reason why these ones are highlighted in green is that only those symptoms really respond well to advanced therapies, motor fluctuations and dyskinesia, and only those symptoms are indications for advanced therapies. Those other symptoms in red, like the axial rigidity or the non-motor symptoms here, are not, strictly speaking, indications for advanced treatments, and sometimes those symptoms may be unresponsive to advanced therapies, or sometimes may even get worse, like, for example, problems with speaking, dysarthria, may sometimes get worse with deep brain stimulation. Now, I mentioned fluctuations, and they have a prominent place in our thinking about complex or advanced Parkinson's and non-oral treatments. Fluctuations, as I guess many of you will know, refer to motor fluctuations of patient symptoms. So off periods alternating with on periods with dyskinesia, with different degrees of dyskinesia, and there may be different degrees of off periods. In the off periods, most people with Parkinson's would have slowness, stiffness, and tremor. Some people may not necessarily have tremor, but in some people, tremor may be the most dominant feature. And then after they take medication, once it gets into the bloodstream, they may feel okay for a while, and this is actually the stage that we are aiming for. We want to make people better with the tablets, but some people later in the disease will also develop dyskinesia, involuntary movements, excessive response to medication almost, when the level of levodopa in the blood and when the levels of dopamine in the brain are very high, and when we see those excessive movements. And those fluctuations may just repeat throughout the day, each time a person takes their oral medication. I won't get into the details of why this happens, but it is simply the progression of Parkinson's. That's what most people would experience later on in the, although everyone. What we want to achieve with advanced therapies or non-oral therapies is to flatten those fluctuations. And you can see that patients or a person in this case still has to take medication, still has to take regular tablets, but the fluctuations should not be as noticeable. And so dyskinesia, for example, may completely disappear with advanced therapies. Off periods will be less noticeable and not as bothersome. That's what we want to achieve with advanced therapies, the flattening of those curves. And the way we want to achieve it, the way we can achieve it, is by providing constant dopaminergic stimulation in the background. So not with those pulses of tablets where the level of levodopa shoots up and then drops and shoots up and drops, but rather with a steady stimulation in the brain provided either electrically by DBS or perhaps by a constant infusion of a drug into the system. Now, there are certain indications for advanced therapies that we always keep in mind when we're thinking about putting the patients forward for those treatments. The precondition, the main precondition for advanced therapies is that patients should be levodopa responsive and that they should have idiopathic Parkinson's. Idiopathic Parkinson's means that the symptoms are typical for the run-of-the-mill Parkinson's disease. There is also what's called atypical Parkinson's, for example, like multi-system atrophy, progressive supranuclear palsy. There is also corticobasal degeneration, and there are some other rarer forms. And for those conditions, advanced therapies are not really indicated. We should really only use them for idiopathic Parkinson's. Another important point is that the patient should be levodopa responsive, meaning that the symptoms, the Parkinsonian symptoms, should respond to a high dose of levodopa, with the exception of tremor. We know that tremor may often not respond well to current oral therapies. And in that case, deep brain stimulation may be considered even if the tremor does not respond to levodopa. And finally, the third precondition is that patients should be on optimal oral treatments. And this is quite important. So we should have exhausted all the available options with current available treatments before the patient comes for advanced therapies. The indications in detail here are just summarized from what I've said before. So disabling fluctuations, disabling dyskinesia, disabling tremor, particularly for deep brain stimulation, and potentially intolerance to levodopa. And this means that levodopa produces perhaps an excessive response. So even a low dose levodopa may produce severe dyskinesia, or there are some people who simply get too ill on levodopa. They may get sick and they can't take it, but they still show a response in that their motor symptoms improve when they take a tablet. It's just that they can't take it because it makes them too ill. There are certain contraindications, and you can see them listed here. The main one is dementia, so significant cognitive impairment leading to loss of independence, and that's the definition of dementia. Uncontrolled psychiatric conditions are also a contraindication, and this is because uncontrolled depression or very severe uncontrolled anxiety may actually get worse with some of those treatments. And the severe disability from other comorbidities, be it arthritis or perhaps heart failure or any other condition that makes the person very disabled on top of their Parkinson's, this should be carefully considered as a contraindication, because it may turn out that even with DBS or Duodopa, the person won't really experience a major improvement in their quality of life. And there are certain caveats that we need to think about when we are deciding for advanced therapies. So it's very important to remember that advanced therapies are not a cure. They do not do anything to stop the progression of Parkinson's. Parkinson's is a naturally progressive condition caused by degeneration in the brain, and whatever treatment we give to the patient at this stage in our medical development, we cannot really stop that progression. And this applies also to deep brain stimulation. The only thing that advanced therapies do is treating the symptoms, effectively treating the symptoms, but it's still symptomatic treatment. So in 5 or 10 years' time, a person who is on DBS, Duodopa or Apomorphine will have advanced in their Parkinson's, and they may require higher doses of medication or higher levels of stimulation with DBS. Another point is that those therapies do not prevent cognitive impairment and dementia. And we know that about 90% of people with Parkinson's will have cognitive impairment of some sort by the 10th year of Parkinson's, by the 10th year after their diagnosis. It doesn't necessarily need to be dementia, but it will be some sort of cognitive impairment. And our treatments do not prevent that. Advanced therapy can only make a person as good as their best on. And that means that if a patient with Parkinson's takes a high enough dose of levodopa, which we actually do in the levodopa challenge when we select patients for treatment, then they will see how they may be with advanced therapy. So DBS or Duodopa can maintain this very good level of symptom control for a long time and throughout the day, avoiding the fluctuations, but it won't generally, the level of control won't generally exceed the control achieved with a high dose of levodopa. With the exception, obviously, of tremor, because tremors may be poorly controlled on levodopa. It's important to remember again, like on the previous slide, that axial symptoms, for example, like dysarthria or like imbalance, may not be hugely improved on advanced therapies, and sometimes, especially deep brain stimulation, may make them worse. And the effects on non-motor symptoms are not yet entirely clear. I'm sorry. So some symptoms may improve, but it's not very reliable. We know that sleep improves well, and that nighttime nocturia should improve well on advanced therapies, particularly on DBS, but also on Duodopa, even if it's not running through the night. But other symptoms may not improve. For example, drops in blood pressure may not improve. Cognition may not improve greatly. Now, I'd like to talk about first one of the therapies. Now, so the first one, the first treatment that I would like to talk about is apomorphine. And you might have heard about it. It's something that is available locally, so you don't really need to come to Bristol or to a local center to have it set up. There are apomorphine nurses across the country, and this can be set up locally. Apomorphine is a drug that is similar in the way it acts to ropinirole or pramipexole or rotigotine. So it is an agonist, dopaminergic agonist, meaning that it's not like levodopa. It doesn't get converted into dopamine. It just acts on the same receptors in the brain. The name apomorphine has nothing to do really with morphine. It's just because of the similarity of the chemical structure, but there is no similarity in terms how it works. And this drug can be potentially given orally, but unfortunately it is rather ineffective that way, because it just immediately gets metabolized in the liver, and not much of it gets into the brain. So it has to be given under the skin. It has to bypass the gut circulation in order to work. There are actually now formulations of apomorphine given under the tongue to get straight into the bloodstream, but this is not really available yet in the UK. The only formulation for now we have is in a pump, and you can either inject this drug with a special pen, like insulin pen, as and when you need it, or you can have it in a pump like in this situation. It works very quickly, so it works within minutes after injection, but unfortunately it also works for a short period of time. So it would work for 20 minutes to half an hour, and then it would wear off. And that's why it can be given as a rescue medication as needed to help with sudden emergence of an off period when it's unexpected, to bridge the patient over to say Madapa or Sinemet, or it can be given, like in this case, in a pump, a continuous pump throughout the day, in a slow trickle. And the benefit of using this drug is that it's easy to set up. So it can be set up locally, either at home or in the local hospital, and the waiting time isn't long. There is a downside, however, because the pump has to be changed every day. So rather, a needle has to be changed every day. This drug gets under the skin through a needle, and the patient or a carer needs to put this needle under the skin every day on the abdomen, and put some kind of a dressing, like in this case, a transparent dressing onto the needle, so it holds the skin. And this needs to be put in every morning and taken out in the evening. Another downside of this drug is that sometimes it may cause reactions under the skin where the needle goes in, and there may be small bumps forming, but it is now much better than it used to be in the past. It's quite an old drug. It's now purified, and the occurrence of the skin reactions is much less frequent now. It may also cause other problems like dropping blood pressure, or may sometimes lead to confusion in people who are already prone to confusion or memory problems. It may also sometimes cause swelling around the legs. But on the whole, we use it quite often for patients whose fluctuations are difficult to control with oral medication, and where we need something quickly because they can't function otherwise. The wait for deep brain stimulation or Duodopa is months, 6 months to a year even, and this treatment can be set up quickly. There is another downside here, in that most of the time, in a large majority of patients, people have to continue on their other oral medication alongside the apomorphine, but the apomorphine lifts the baseline in those cases, so the off periods aren't as bad as they used to be, and this curve that I showed you, the fluctuations are flatter. And sometimes it allows for reduction of the medication, but not necessarily a complete cessation of tablets. And now on to Duodopa, which is a fancy name for old levodopa with carbidopa, so cocaral-dopa or Sinemet, in a gel form, injected directly into the stomach. And the way it is done is by putting in a port here, a peg into the stomach, which is done with a short procedure, and feeding a tube through that port deep into the gut, into the duodenum, actually past the duodenum, into the jejunum. This tube stays there, and this is the place here where Duodopa is released, and where it's actually absorbed directly from the gut. So this treatment allows us to bypass the long way from the mouth to this place, to the jejunum, where levodopa is absorbed, and this way it allows us to skip all the delays that may happen on the way down. And we know that with more advanced Parkinson's, people may have problems with swallowing. Swallowing may take longer. Also, in the gullet itself, the tablets may be delayed. They may be retained in different parts of the gullet because the movement of the gullet is slower in Parkinson's. The tablets may also stay in the stomach before they pass on to the duodenum here. And with this tube directly into the stomach and the jejunum, we can bypass all those upper parts of the gastrointestinal tract. Now, this drug is delivered through a pump. So the port here stays out, and the skin over the tube grows over, forms a scar, and the port sticks out, allowing us to connect a tube here running from the pump to the port, and then this pump can be worn on the belt. It's not shown to size here because it appears like it's bigger than the stomach. It's actually probably slightly bigger than a palm with fingers, and you can see that there is a container there with the drug, and this pump ensures that the gel form of levodopa goes through the tube continuously into the stomach from the morning, since the morning when the pump is set up, until the evening when it's disconnected. This, as with apomorphine, is a treatment that needs some input from the patient or the carer, because the pump, unfortunately, needs to be connected every day to that tube that stays out, and needs to be flushed in the morning and then in the evening. We sometimes leave the pump on at night as well at a lower rate, with lower dose of the drug, if people have very severe symptoms at night, but most of the time it's better to take it off for the night. And the benefit of having this infusion throughout the day is that, first of all, the fluctuations are smooth, and they virtually disappear. And that includes both the off periods as well as dyskinesia, the excessive movements. The other benefit is that we are able to stop all the oral medication that the patient is taking. So all the cocaral-dopa, Sinemet, but also ropinirole or pramipexole or selegiline, rasagiline, and tacapone, all those can be stopped, and the dose of those medication can be converted into the equivalent dose of Duodopa. And this is a major benefit for many people with Parkinson's, because they are then released from the shackles of the alarm clock, and they don't have to remember taking the tablets every 2 or 3 hours. There are some downsides to this treatment as well, and perhaps the major one is the fact that this tube going into the stomach may sometimes cause small infections of this of this stomach, of this abdominal scar, and sometimes it may be weeping or oozing. There are easy ways of treating that, but most people who have this treatment will experience some mild problems with that wound. Another problem that will happen sooner or later is that the tube will get blocked. So the Duodopa that goes through the tube here, at some point, and usually it happens after a year or 2 or 3 years, will clog up the tube, and the tube will need to be replaced. This isn't a major problem, because this replacement can happen relatively quickly in any hospital that has a gastrointestinal service. But well, it's obviously something that is an inconvenience to the patient. Finally, what may happen is that with this continuous infusion, some patients may develop neuropathy or damage of the nerves in the feet. That happens in a few percent of patients. It's not not the majority, not 10%, it's perhaps up to 5% of people may develop neuropathy, and we monitor for that in each clinic visit. And patients also get vitamin B12 supplementation to prevent the neuropathy. And now I will talk about deep brain stimulation. Deep brain stimulation is probably the oldest advanced treatment available in Parkinson's. And it is necessary to have a neurosurgical intervention to have the system put in. 2 electrodes, and you can see only one here, but 2 electrodes are normally implanted symmetrically on both sides of the brain. And these are like thin wires which have to be put in through burr holes. You can just see a cap here, but a surgeon has to drill a small hole in the skull on this side and the opposite side, and pass a thin wire deep into the brain and then fix it to the skull. Those 2 wires are then connected by another wire that goes under the scalp, under the skin, behind the ear and on the neck to the stimulator, which is implanted under the collarbone. And this stimulator provides 24/7 stimulation with very small electric shocks to the area deep in the brain that is involved in Parkinson's. Those electric shocks cannot be felt by the patient, and you actually wouldn't know that the stimulator is working. People cannot feel it, and they wouldn't know whether it is on or not, except for the effect on Parkinson's. The stimulators work very well for most features of Parkinson's, most symptoms. They work particularly well for tremor, and over 80% of patients with tremor would experience very good response, with the tremor virtually disappearing. The stimulator also works well for symptoms like slowness of movement or stiffness, particularly slowness and stiffness in the hands and arms, in the upper body. It doesn't, however, work as well for slowness and stiffness in the legs, particularly perhaps for slowness in the legs and for balance. That's why, which I mentioned earlier in the presentation, balance problems and particularly falls, especially if those happen in the on state, even with a good effect of medication, are a contraindication to deep brain stimulation. In fact, balance problems and falls may worsen after deep brain stimulation. Sometimes it is possible to improve balance and falls with deep brain stimulation, but in the large majority of people who have DBS, if they had balance problems and falls before having DBS, those problems will return within a year or 18 months of having DBS, even if they improved initially. Deep brain stimulation allows us also to control dyskinesia quite well. And this is partly because of reduction in the dose of medication that patients are taking. So once a patient has DBS in, medication like Duodopa or pramipexole can usually be reduced by up to 50%. In some people it may be more, but 50% would be the target for us. Many people are able to reduce it by a quarter, 25%, or a third. And this sometimes allows people to reduce the frequency of the medication or the number of tablets they are taking. But it is rarely the case, it is an exception that patients with DBS are able to stop their medication completely. This is possible with Duodopa, but not so much with DBS, unless the main problem they have with Parkinson's is tremor, and they don't really have much slowness or stiffness. In those cases, patients may come off their medication successfully. So these are the major benefits of deep brain stimulation. There are also some possible complications or side effects. This is a surgical procedure, and it takes a while. So I'm sorry, it is a long procedure, and in our center it's done under a general anesthetic. So patients are unaware, they are asleep for the procedure. And in our center it takes about 2.5 hours, sometimes 3 or 4 hours. And once patient wakes up, the stimulator is in, all the wounds are stitched up, and the patient normally can go home the next day. We don't normally switch the stimulator on the next day. We wait for about 4 to 6 weeks to make sure that the brain has adapted to the electrode, and then the wound has healed on the chest. And then we can switch it on the 6 weeks visit, 4 to 6 weeks. The possible complications, as I mentioned, could happen during the implantation procedure itself. And for example, when passing this electrode down into the brain, it may happen that a vessel, an artery or a vein is pierced and it may bleed. This happens rarely. Less than 1% of people who have DBS would experience this kind of a bleed. And even if it happens, the bleeding is small. The symptoms that may result from that are usually some numbness or weakness on one side of the body, like in an arm or a leg, but they would usually pass within days or weeks as the blood gets reabsorbed, gets sucked in by the brain. There is a slightly bigger risk of having an infection around the electrodes or around the stimulator itself. This risk is about 5%, and those infections may need to be treated with intravenous antibiotics in the hospital. There are also some risks, as I mentioned before, of making balance worse, or of making speech, particularly in people who already have problems with slurred speech, of making that worse. But on the whole, it's a very effective treatment. And finally, this is my penultimate slide. I'd like to talk here about relative effect on those different treatments on off-time and on-time, as well as dyskinesia. So you can see that DBS and Duodopa, they both increase the off-time by about, reduce the off-time by about 4 hours. And at the same time, they increase the on-time by about 4 hours. And this is a daily total. Most patients who come to us for DBS or Duodopa would be off in a day for about 6 to 8 hours. So it's quite a long period. Those treatments may also improve dyskinesia. DBS by reducing the amount of medication that is taken, and Duodopa reduces dyskinesia mainly by reducing the peaks of the levodopa level in the blood. In case of apomorphine, the reduction in the off-time and increase in on-time is not as prominent, and this is probably because patients who are put forward for apomorphine, historically at least, are more advanced than other Parkinson patients. You can see also that treatments lead to reduction in the overall medication. And finally, I would like to mention MRG-FAS, which is an abbreviation from MRI-guided focused ultrasound ablation procedure. This is something that is available in London at the moment, and there is quite a long waiting time for this procedure. And this procedure is only really approved for treatment of tremor, particularly essential tremor. But Professor Peter Bain, who is in charge of MRG-FAS in London, also does it for people with Parkinson's who have severe tremor. This procedure is non-invasive in that we don't really need to make an incision or go into the brain to have an effect. It relies on ultrasound like for pregnancy or like for kidney stones. This ultrasound, the ultrasound beams are focused deep in the brain, so they are delivered through a helmet here. This is just like an artist's impression, and you can see those individual green lines here. They are supposed to represent the ultrasound beams, and they are produced by over 1,000 of different small ultrasound probes, which are aligned here like in a helmet, and all those beams are focused in a tiny spot about less than half an inch in diameter, deep in the brain. And this focus, the ultrasound that focuses there, is able to heat up the tissue deep in the brain to about 50 degrees Celsius. And that way the tissue coagulates, almost like when you boil an egg. And a small scar forms deep in the brain. And if the center of this focus is chosen correctly, then this should stop the tremor. This focus is located in a deep area of the brain called the thalamus, and this particular part of the brain takes part in generating tremor. And so killing cells in this area leads to cessation of tremor. You can see the result of it before treatment. When the patient was trying to draw a spiral, it was very scruffy and there was a lot of tremor. Equally, when they were trying to draw a line or write anything after the treatment, they are able to draw a spiral clearly and do a straight line, and the writing improves. This procedure, as I said, is non-invasive in the sense that a person doesn't need a surgery, but still it is quite cumbersome. So all this lesioning procedure happens in an MRI, because we need to use the MRI picture of the brain, like shown here, to guide the focus of the ultrasound. This procedure takes a couple of hours, 2 to 3 hours, and it's 2 or 3 hours of going in and out of ultrasound machine, being on your back all that time without being able to actually get up and walk. And so it's not something to be taken lightly. The patient cannot be asleep during this procedure because the doctor has to constantly check for the tremor and how well it improves, or whether any other symptoms may develop. If so the procedure is quite popular amongst patients, especially if you read that it's non-invasive, that it involves high-level technology, but people should be aware that it is a long and cumbersome procedure. Okay, so this is all I had to say about advanced treatments, and we in Bristol can provide all the 3 treatments that I mentioned at first. We can also refer for MR-guided focused ultrasound. Your GP or your local neurologist can also refer for MRG Fast to London. You have to be aware that there are some waiting times, particularly for DBS and Duodopa, and this is usually probably in the range of 6 months to 9 months. It does vary because the pandemic obviously had a huge impact on us, and we couldn't admit people for a very long time, and so we developed quite a large backlog. But the waiting times are getting better now. And as I said, Apomorphine can be delivered directly where you live. So with that, I would like to thank you for your attention, and I can answer any questions that you've posted.
Okay, Konrad, thank you so much. That's a really interesting talk. You've actually answered one of the questions already. I don't know whether you were looking at the Q&A at the same time, but
no.
Okay. Sarah Jackson asked about the referral process, so you've actually answered that question already. Okay. First question comes from Gillian. I've recently moved to Lincolnshire and I haven't been referred to a consultant in PD yet. I don't know who the local Apo nurse is. I'm using Apo pens more frequently than I like, and I think I may be ready for the pump. Up to now, I haven't felt psychologically ready to use the pump, seeing as a desperate last resort. Who decides whether I use the pump?
Yes, so you should definitely have a consultant that specializes in Parkinson's. This is actually a national requirement that every patient with Parkinson's should have a specialist, and this could be either a neurologist or a care of the elderly physician. In the UK, these are the two specialist types that look after people with PD. So you'd have to be referred by your GP to a local specialist. Well, you wouldn't obviously know who your local Apo nurse is, and actually the service is perhaps more centralized now than it used to be. So those nurses are nationwide, and they travel from wherever they live to different places across the country. They usually have a coverage area, but it's quite big, and those nurses do change. But the local specialist would be able to put you in touch with a nurse like that. And I don't think that the pump is necessarily the last resort. Certainly, if you have to use the pen frequently and you have you are on optimal oral treatment, then the next step would be the pump. But I would say that it may also be a time to think about other advanced treatments like the Duodopa or deep brain stimulation. And this is because particularly Duodopa in people who are on apomorphine, particularly Duodopa may provide a significant improvement in the quality of life. So by all means, you should be referred to a local specialist.
Okay, thank you very much. A couple of questions for you there. How do you decide which treatment is best for an individual, and how many sites in the UK do DBS?
DBS, yeah. So the decision between those 3 or perhaps 4 treatments depends on the main symptoms that we want to treat, and also on the associated symptoms. So, for example, for DBS, patients should have either severe tremor or severe fluctuations with dyskinesia and off periods, but they should have a severe imbalance, particularly if this imbalance does not respond to levodopa. They shouldn't have severe problems with speech, and crucially, they cannot really have any cognitive problems. So they should score very well on our cognitive tests that we do in clinics. On the other hand, Duodopa is particularly good for people who take many medications, or who rather take many doses of medications throughout the day. For example, 5, 6, or even 7 different doses throughout the day, because Duodopa allows us to stop all this medication, and all of it can be recalculated and converted into Duodopa. Duodopa is also good for people who have cognitive impairment, or even for those who have dementia, because it wouldn't necessarily affect that much their cognitive performance, but it will still provide very good improvement of the motor symptoms. With apomorphine, it shouldn't be given to people who have drops in blood pressure. It shouldn't be given to people who have confusion, who are prone to confusion, or who have hallucinations. And all this decision making is done in our center when we see the patient for the first time, or then perhaps later on when we assess them in this more extensive, usually inpatient assessment. Now, how many sites in the UK do DBS? Well, I would say 12, maybe 15. I can't remember exactly, but there are certainly centres in Oxford, Liverpool, Manchester. There was a centre in Birmingham. There are a couple of centres in London, Newcastle, and in Scotland. There is also a centre in Ireland now, in Dublin. So there are a couple of centres. The closest, certainly, to Southwest is Bristol. And we also get patients from Wales and some people from Ireland too. So I hope that answered the question.
Right.
It's possible to predict who might get the speech problems after DBS. Unless a patient already has speech problems, it's impossible for now. There are some research strategies to do that, but unfortunately we can't employ them. They involve fMRI and complex MRI imaging, which we don't have available. We know that certainly people who already have speech problems, particularly slurred speech, not so much perhaps low volume speech or monotonous speech, which is very common in Parkinson's, but specifically slurred speech, these people are much more likely to have worsening of their speech problems. And also particularly people whose speech problems persist even when they've taken their levodopa. So if the speech problems are unresponsive to levodopa, and how many people get DBS in Bristol each year? It used to be even up to 60, but unfortunately with COVID it went down dramatically. Now I think it would be perhaps around 40.
Okay, thank you.
Do any of these advanced therapies help with pain, abdominal experience during off time? Yes, they can help with pain, but there are so many different types of pain in Parkinson's that you mentioned here abdominal pain during off time. Generally, pain in off time should respond to treatment, and it would probably respond like any motor symptom. Abdominal pain, I think that this should respond pretty well, because abdominal pain would usually be caused by either a dystonic muscle cramp in the abdominal wall, or perhaps by some problems with the gut itself, with the stomach or the gut, and those two types may respond. Okay, can I have the next question? Is MRI guided ultrasound available in Bristol for tertiary referrals? Well, so we don't have the machine. It's extremely expensive. Before COVID, we were in the process of obtaining it. This was thrown out of course by COVID. We may get it in the future, but we don't have it as yet. At the moment, it's only available in London, and we can obviously refer, as any other centre can refer to London. It's St Mary's Hospital. I'm unable to have DBS under MRI scanning because I have a cerebral aneurysm clip. Is there a procedure that does not require MRI? Well, it's a difficult situation, because any procedure that targets the brain for Parkinson's would require an MRI. There is a procedure that you can have the Duodopa. The Duodopa pump can be set up without any need for MRI. The only imaging that is required is just simple X-ray to put the tube in, and that can be done with an aneurysm clip. And equally, Apomorphine can be set up without MRI. Thank you.
I'd like to thank Konrad for giving up his time for us this evening and giving us such an excellent talk. And thanks also to Jason and Martha for doing the technical support for me.